It's my pleasure to introduce our last speaker, Dr. Rebecca Sternshine. Rebecca is a clinician educator at the Brigham Pulmonary and Critical Care Division. She's attending in our medical and surgical ICUs, and I'm grateful that she'll be presenting some challenging cases today. Thanks, Rebecca.
Thank you so much. Excited to be here. So we'll start with the disclosures, which I have none of those, and move right into the first case. This is a case of a 27-year-old gentleman, doesn't have any prior past medical history, and presented with a sudden onset of bilateral lower extremity weakness. The way he told this story is that he was getting out of bed in the morning and his legs just gave out. He fell to his knees. This lasted for about an hour, and that's what brought him into the emergency room. He said that he didn't have any head strike, no loss of consciousness, didn't feel pre-syncopal, no chest pain or respiratory symptoms that went along with this. He said that for the last few days, he had been feeling a little weak and fatigued. He had been having very sugary snacks recently. For instance, he noted that he had had to drink a 2-liter bottle of soda before he came into the emergency room. He also said that he had had some milder versions of this same thing that happened in the prior 6 months, but they all went away in about a few minutes. And otherwise, his review of systems was negative. His social history was significant for being a former smoker that he quit 2 years ago, alcohol use intermittently, marijuana use a few times per week, and no other recreational drugs or illicit substances. He did have a family history of multiple sclerosis in his maternal grandmother. His exam on admission, blood pressure was normal. He was tachycardic to 120. His temperature was 98.6. He was tachypnic, breathing a true 32 breaths per minute, statting 98% on room air. He looked ill. He was anxious. And his exam is listed here, but I'm going to read out the relevant portions that are abnormal, which is his neuro exam, where he had proximal both upper and lower extremity strength that was diminished to 3 out of 5 bilaterally. And his distal upper and lower extremity strength was 4 out of 5 bilaterally, so diminished as well. He had intact reflexes and cranial nerves. So we're going to start with the first audience response question. Which of the following is the most likely possible explanation for acute onset lower extremity weakness in this patient? Is it A, rhabdomyolysis, B, Guillain-Barré, C, epidural abscess, D, thyrotoxicosis, or E, cerebral vascular accident? All right, let's move forward. The answer is D, thyrotoxicosis, which was the second most common answer that everyone selected. And we're going to go through the incorrect answers and explain why thyrotoxicosis could possibly cause acute onset lower extremity weakness. So for rhabdomyolysis, this patient doesn't have any risk factors. He wasn't found down on the ground. He doesn't have any pain. He doesn't report any hematuria. So it makes it less likely. Guillain-Barré, we would expect an insidious onset and also not an episodic presentation like this patient had. For an epidural abscess, again, no risk factors for putting him at risk for developing an epidural abscess, and no report of fevers, chills, or infectious history. Not necessarily always the case with epidural abscess, but not present in our presentation here. And again, cerebral vascular accident, we would expect unilateral weakness more likely than a bilateral and symmetric process. When we think about the differential diagnosis for lower extremity weakness, we can separate that into two different categories: muscle-related issues and nerve-related issues. And we'll start with the nerve-related issues. So we can think about the peripheral nervous system and the central nervous system. And then I also added in here some exposure-related diseases that we often think about when we see patients with this presentation in the ICU. Peripheral nervous system issues include the epidural abscess. That was one of our options for answers. Multiple sclerosis, Guillain-Barré, CVA, and tick paralysis and botulism, some of the exposure-related diseases. On the other side of the screen, you'll see some general categories for muscle-related causes of bilateral lower extremity weakness. So muscle spasm, very severe, volume depletion or electrolyte abnormalities could be at the root of the problem here, as could rhabdomyolysis, which is muscle destruction. And then there are other muscle disorders, which include metabolic myopathies, myasthenia gravis, this would be a myasthenic crisis, Lambert-Eaton syndrome, and hypokalemic periodic paralysis. And I'm going to highlight that one because this can be caused by thyrotoxicosis. And when we look at our patient's laboratory workup, lab results, I'll highlight two of the categories of things that are abnormal here. One, his potassium is 1.9, quite low. And two, his thyroid function tests indicate thyrotoxicosis. The rest of his labs are grossly normal. Our patient also had an EKG that demonstrated U waves. U waves are an additional wave that we can see after the T wave that can be seen in profound hypokalemia, such as this patient had. And we're ready for our next question. Which of the following is a treatment for thyrotoxicosis that should not be given initially for this patient? Oh, there's all the answers. All right. Oh, they all came in all at once. All right. So the majority has it here. Potassium iodide is the treatment that should not be given initially for this patient. So again, we'll go over the incorrect answers and then we'll get to the explanation for the correct answer after this. So potassium repletion in this patient with a potassium of 1.9 should be given immediately for thyrotoxicosis, particularly because, as we noted, thyrotoxicosis can cause hypokalemic periodic paralysis, which is our leading diagnosis in this case. Methimazole should be given immediately for thyrotoxicosis. Amlodipine and lisinopril are not treatments for thyrotoxicosis, and so they are not the correct answer. In this case, what this patient had was Graves' disease causing thyrotoxicosis, causing thyrotoxic periodic paralysis. The reason that potassium iodide is not given initially as the primary treatment is that this can actually exacerbate the hyperthyroidism. Remember that iodine is necessary for thyroid hormone synthesis, and so when you give potassium iodine before giving the methimazole, you can paradoxically worsen the hyperthyroid state by allowing for release of additional synthesis and release of additional thyroid hormone. So this patient was given potassium repletion and methimazole, followed by potassium iodide, and also propranolol for his thyrotoxic symptoms. And as an outpatient, he actually ended up having a total thyroidectomy 2 months later. This is the definitive treatment for hypokalemic periodic paralysis that causes related to thyrotoxic disease. Periodic paralysis, there are a lot of different potential etiologies of it. And I want you to pay attention to this middle row here. The potassium is low in two categories of periodic paralysis, the hypokalemic periodic paralysis and thyrotoxic periodic paralysis. And both of these present later in life and early adulthood, and have different etiologies. One interesting aspect of both of these types of periodic paralysis is that attacks can be precipitated by fasting, exercise, and or a carbohydrate load. I remember this patient told us that he had been drinking 2-liter bottles of soda right before coming in, sugary soda right before coming into the hospital. So carbs, exercise, and fasting all release insulin and epinephrine, and that causes potassium to move intracellularly, and then that hypokalemic environment exacerbates causes the periodic paralysis. For thyrotoxic periodic paralysis specifically, we tend to see this more in males than females. The mechanism is currently unknown. There's some hand-waving explanations about a sodium-potassium ATPase, but really the final answer still is yet to be discovered. It does only occur in the hyperthyroid state, and often the first presentation occurs concurrently with the first hyperthyroid symptoms. Early morning attacks are quite characteristic, so this patient's presentation was very characteristic. Overall, our treatment, we should supplement potassium, beware of rebound hyperkalemia, and if you have refractory hypokalemia, you can actually use propranolol for that. Concurrently correct magnesium and phosphorus. Always monitor these patients on telemetry. They're at risk for arrhythmias, particularly VT and VF. And then maintaining the euthyroid state permanently. So this means either medical or surgical induction of a euthyroid state. Once these patients are euthyroid, even if they become hypokalemic, they do not have attacks. This is 3 take-home points from this case: that the etiology of periodic paralysis may be inherited or acquired, and it can be hyper or hypokalemia. Periodic paralysis attacks are often precipitated by exercise, fasting, or a carbohydrate load. And thyrotoxic periodic paralysis can be definitively controlled if you maintain the euthyroid state. So we'll move on to our second case. This is another 39-year-old man, a young man youngish man who has no known past medical history, presents with shortness of breath and a facial rash. The day prior to admission, he noted a sore throat and then rapid onset on the day of admission, where he became short of breath and developed this rash. He also noted tingling in his fingers and toes, some neck stiffness but no headache, diplopia, and myalgias. His medical and surgical history is significant only for a C1 fracture years prior in the context of alcohol intoxication. His social history is significant. He lived in Jamaica Plain, which is an area of Boston, works as an art director at a graphic design firm. He drank 6 alcoholic beverages per week on average, current smoker, no illicit drug use, sexually active, heterosexual, non-monogamous relationship, but used condoms, and had a pet, a dog. His exam on admission, he was hypotensive, relatively hypotensive, blood pressure 107/84 for him. His heart rate was 67. He was satting 72% on room air and was continuing to desat even on 10 liters nasal cannula, was transitioned to a non-rebreather to maintain a sat greater than 90. He was toxic appearing. He was in acute distress. He had bloody conjunctiva, asymmetric pupils but reactive, some mild neck stiffness. He was tachycardic. He was tachypnic. He had a skin exam that was significant for confluent purpuric non-blanching rash, mostly on his face, but he also had it on his trunk and extremities. On his extremity exam, he was cool to the touch and had some dusky fingers and toes. This is the appearance of his fingers and toes at the time of admission. I'm going to just give you, for context, fasting forward just a few days into his admission, this is what developed. All right, so here's our first question for this patient. Which of the following characterizes purpura fulminans? Is it A, a positive PF4 antibody, B, DIC and adrenal failure, C, DIC and cutaneous thrombosis and necrosis, D, cocaine and cutaneous vasculitis, or E, a reduced ADAM-TS13 activity? All right, so the majority have it here as well, DIC and cutaneous thrombosis and necrosis. So going through the incorrect answers, a positive PF4 antibody is associated with heparin-induced thrombocytopenia, or HIT. DIC and adrenal failure we see in Waterhouse-Friderichsen syndrome. Cocaine with a cutaneous vasculitis, that is levamisole toxicity. And then reduced ADAM-TS13 activity we see in TTP, or thrombotic thrombocytopenic purpura. Let's look at his labs, and we'll come right back to the purpura fulminans. His labs have a lot of abnormalities, so there's a lot of red on the screen here. He's hyponatremic. He is acidemic with a lactate of 13. He has an anion gap of 31. He has a transaminitis, pretty profound, and hyperbilirubinemia. He has a coagulopathy and thrombocytopenia. Basically, the only thing that is normal is his white count and hemoglobin on his labs. His peripheral smear showed marked thrombocytopenia. He had white cells with bands, metamyelocytes, and PMNs that had what was reported as a linear basophilic inclusions. He had acanthocytes and schistocytes. His blood cultures were pending at the time that we're evaluating him here, and he was not making any urine. His chest x-ray showed no consolidation, some subtle curly B lines at the right base, but otherwise not very exciting. His non-con head CT was normal, didn't have any masses, didn't have any midline shift, no evidence of bleed. And he had a bedside echo, which was challenging to interpret in the setting of his tachycardia, but he did have a decreased ejection fraction with global hypokinesis. So to recap, because this is a complex patient, this is a 39-year-old man who has no known past medical history, presented with a rapid onset of facial purpura, acute hypoxemic respiratory failure, who was found to have severe lactic acidosis, coagulopathy, renal failure, and hepatic injury. He was initially managed in the ICU, intubated for his acute hypoxemic respiratory failure, fluid resuscitated, and given a platelet transfusion. In the emergency room, he had gotten vanc and ceftriaxone. The MICU added doxycycline, piperacillin tazobactam, ciprofloxacin, and oseltamivir. So we'll talk a little bit about purpura fulminans, which he had. This is a very rare, often life-threatening syndrome characterized by septic shock, which he had, DIC, and this purpuric rash that develops tissue thrombosis and cutaneous hemorrhagic necrosis quite rapidly. The etiology is either a pre-existing, either inherited or acquired abnormality of protein C or S, can be idiopathic, but also can be related to acute severe infection. Most commonly, it's noted with gram-negative rods like Neisseria meningitidis, but also strep pneumonia. And there's a host of other infections that have been found to also develop purpura fulminans. The clinical time course of the skin necrosis is quite rapid. So the progression from dermal discomfort to the presentation of the petechiae is hours, and then over days, a short number of days, we can see this coalescence into purple ecchymoses, hemorrhagic bulli, and then skin necrosis and gangrene, as we saw on the photograph of his extremities. The pathogenesis of purpura fulminans is thought to be related to the Schwartzman phenomenon, which includes a process of local priming by the endotoxin from the gram-negative rods, followed by a second exposure to that same endotoxin, which is when the vascular thrombosis and necrotizing vasculitis develops. On histology, we can see occlusion of dermal venules and capillaries by the microthrombi and hemorrhagic infarction, as you would expect. The treatment is quite depressing. It's primarily surgical. Almost all the time, we have full thickness skin loss in these patients, 87% requiring skin grafting and 90% requiring limb amputation. 25% of the time, people end up with amputation of all 4 extremities. The other 3 categories listed there, anti-inflammatories, anticoagulants, and fibrinolytics, all have no substantial evidence to suggest that they help or give a survival benefit. In this patient, the underlying infectious etiology was actually determined to be an organism called Capnocytophagia canemorsis. He actually never had positive blood cultures, but because of the high suspicion for this organism, his blood was sent to the CDC, and they identified fragments of the capnocytophagia by PCR. He was treated with piperacillin tazobactam, which is the treatment of choice for capnocytophagia. But because Neisseria meningitidis is so commonly associated with purpura fulminans, he was continued on the ceftriaxone as well. A tiny bit about capnocytophagia. It's a gram-negative filamentous, slow-growing facultative anaerobe. It's found in the oral cavity of dogs and cats, so dog bites and scratches can potentially be the underlying cause. And if you remember, this gentleman had a puppy. Most of the time, patients who actually develop capnocytophagia canemorsis infection or sepsis, they are immunosuppressed in some way, and very frequently it's associated with splenectomy, hyposplenism, or alcoholism. The case fatality is 26%, so it's quite severe when it does occur, and as noted, it's been known to cause purpura fulminans. Luckily for us, this patient actually was discharged from our medical ICU after a long hospitalization. We went to the floor and then to home. He did not lose all of his extremities. He's undergone multiple debridements, and he had some digit and toe amputations and partial amputations. This is a picture of what his hands looked like after some time after he had healed at home. He is able to walk on his own with a cane, and he uses his hands for his work. He continues to do graphic design. So we have a positive ending to this very, very substantially scary story. These are the references from these cases, and I welcome any questions. Thank you so much for your time.
Thank you so much, Rebecca. Really interesting cases and very nicely worked through.